I'm going to get started. We'll see how it goes. So basically, I'm given this topic of talking about COVID-19 and ARDS. So hopefully I'll be able to give you in this next few minutes just an overview of ARDS in the setting of COVID-19. And I think I'll leave a lot of time for questions, so we can actually go through practical patients you might have had or something along those lines. So basically, SARS-CoV-2 is a beta coronavirus, and it's a single-stranded RNA virus, and it's got this crown-like appearance. I'm sure every one of you knows this. And it's a zoonosis, meaning that it's a disease that can be transmitted from animals to humans. And basically, it's very similar to the other SARS virus in that all of them can actually infect humans. And the disease caused by SARS-CoV-2 is actually called COVID-19. So what happens when this virus actually infects the human cells? Generally, it gains entry. Can you guys see my pointer?
Yes, it's visible.
Okay, great. So basically, the virus gains entry into the pulmonary epithelial cells via the ACE2 receptors and the TMPRSS receptors. And when it gets inside the cell, it basically hijacks the cell's machinery to try and replicate itself. But the process of doing this, it causes something called pyroptosis. It's slightly different compared to apoptosis in that it's a very pro-inflammatory state. And it basically releases the viral RNA and DNAs into the epithelium. And basically, if you look at the cartoon on the other side, you would see that the other epithelial cells react by producing all these cytokines and chemokines. This is an alveolar macrophage, which also does the same. IL-6 in particular is something that's got a lot of attention right now as a possible target to stop the immune-mediated reaction. So these are very important cytokines and chemokines. And they're important because they recruit these effector cells into the pulmonary epithelium, and it initiates a positive feedback of inflammation. Once that happens, there's one of two possibilities. The bad possibility is the one on the red, on the left side. And basically here you can see that there is a dysregulation of the immune system. And what that does is that there is an overload of chemokines and cytokines with resultant damage to the epithelium. And then this spills over systemically, causing multi-organ failure. Of note, it also causes problems in the vascular permeability and the endothelial dysfunction, which actually exudes fluid into the alveoli, and basically they fill up with fluid, and that's how you get ARDS. The good response is on the right, where the virus is stopped from shedding out. The immune system correctly diagnoses the cell as infected with the virus, and then your innate immunity cells comes and basically try and create and clear the virus. So that's the good part. Some people have this, others have this. Exactly why you go on to one or the other is likely multifactorial, but we're not sure. We think that cofactors such as your comorbidity comes into play because that affects the immune system and how it functions. Genetics may also play. Previous viral infections may also come into play here as well. So for the clinicians out there, generally speaking, the course of this disease can be divided into three stages. The first stage is when the symptoms are minimum, but your viral load is very high. You shed virus very quickly. In fact, now there's emerging evidence that suggests that by day 7 or 8, you have almost cleared the virus. So basically, those people who get sick and get onto ventilators, the predominant problem is not the virus. It's actually the immune cascade dysregulation and immune issues that have been induced by the virus. But at that stage, at the later stages of disease, the virus is not very prominent. And the stages are, stage 1 is very mild, where you just have some mild constitutional symptoms and dry cough. In fact, it's thought that up to 1/3 of the patients are asymptomatic. And then you get into stage 2. This is when the patient starts feeling a bit short of breath, and then they realize, oh, I've got hypoxia. So this is also something that's coming up, that the hypoxia in SARS-CoV-2 seems to be different compared to the other hypoxia that we have seen. And there's a lot of hypotheses of why that is. And finally, you've got the last stage where you've got ARDS and shock with very high inflammatory markers, including CRP and LDH. And at the bottom there, you can see lots of potential therapies, but I'll skip that for the sake of time now. Generally speaking, from the time of onset to the time that you develop ARDS, it takes about 8 days. So for the first week, you're just brewing there. So the highest mortality is actually found in the second week of disease. And that's where people really require intensive care and need to be hospitalized. So for the clinicians out there, it's always good to understand how these patients present, because obviously there are other countries that have seen a lot more cases than we have, so we have to learn from them. So this is a study from China, 138 patients, but just to see the kind of patients they admitted was 138 patients who had radiological abnormalities. So basically they are patients already into stage 2. And these are the guys who have an infiltrate on the chest. So but this sick group of patients, only 31%, only a third of them complained of being short of breath. It's amazing. And if you look at the major thing that we often say that patients with SARS-CoV-2 have dry cough, but in this cohort, a third actually had sputum production as well. And ARDS basically develops in about 20% of patients, with 12% requiring mechanical ventilation. And if you compare this experience with the experience in the US, you can see again, majority of the patients came in who were not so sick. Basically, the respiratory rate was below 24, which is actually mild to moderate disease. And again, about 20% were in respiratory failure, with 12% requiring mechanical ventilation. The thing about the New York data is that a lot of them died. 88% of the patients who got onto the mechanical ventilation actually died, which is very sad. So radiologically, how do these patients present? In the early phases, you have very patchy ground glass opacity like that that comes in. 10% of the patients have unilateral disease. And subsequently, between the second week, day 8 and day 10, up until day 14, this is the worst part of the disease. And basically here you can see that the ground glass is very extensive and it's extended. Predominantly the base is just like what we expect in ARDS, that the dependent organs have got more disease. And finally, recovery, where you actually tend to get better after about day 14 or so. So that's generally how the radiology presents. Now, there's a key question that how is this virus different from, for example, H1N1 that we know a little bit better? So there is a lot of data out there. A lot of it is anecdotal. I looked for a lot of studies trying to see good quality studies that controlled for a few things. And this is probably the best that is out there because I couldn't find anything else. And what they did is they compared patients with H1N1 and they tried to match them with patients with COVID-19 to see how are they same or different. So generally, patients with COVID-19 had more dry cough and less rhinorrhea. This is something that we already know. But their time to ARDS is equivalent, 8 days from symptom onset. So both the patients had the similar. The patients with SARS-CoV-2, all the red, applies to the COVID-19s, had more ground glass opacity, which is basically the opacity that I showed you, with the less consolidation. They had better oxygenation, lower severity of illness, and a lower SOFA-adjusted mortality. SOFA is basically, if somebody dies, you have to adjust for how sick they were. Otherwise, you will get a very wrong signal. So SOFA basically is the sequential organ failure assessment score that basically tells you how sick a patient is on a particular day, and you can use it to track patients across on a daily basis. So those people working in ICU would know this very well. So when you actually adjusted the mortality, it sounded like we had lower mortality we have lower mortality in COVID-19 compared to H1N1. I must say this took me by surprise because I thought that the mortality would be higher, but apparently when you look at it in this cohort of patients, it was actually lower. So that just puts things into perspective. All right, I think just to start off with, before I explain to you how to manage the ARDS in this setting of COVID-19, I think there's two physiological concepts that we need to understand, and two pathological. So the physiological concepts are in green. One is a ventilation perfusion matching, and the second concept is something that's called hypoxic pulmonary vasoconstriction. And the third one is basically a pathophysiological entity, which is a ventilator-associated injury. And the fourth one is patient's self-inflicted lung injury. So we start with the first one, the VQ mismatch, what we call ventilation and perfusion mismatch. Basically, the bottom line here is that different areas of the lung are perfused and ventilated differently. Perfused means receive different amount of blood supply versus the amount of air that actually enters the alveoli. So if you see this graph, at the bottom of the lung, maybe let me not use the bottom, let me say the dependent part of the lung has a higher blood flow compared to the ventilation. But as you go to the top, so as you go from the bottom to the top, the blood flow decreases and the ventilation also decreases, but the decrease in the blood flow is much steeper and much more compared to the ventilation. So at the base, there is more blood flow compared to the ventilation, and at the apex, there is more ventilation compared to the blood flow. And this cartoon on the right actually shows you that. So you can see the alveoli here is very big and compared to the blood flow. And as you go down, the alveoli basically becomes smaller and the blood flowing increases actually. And the ideal situation for us is actually to have this point where both the lines intersect. That is where your ventilation basically meets the perfusion, and that's the ventilation perfusion ratio of being 1, which is 100%. So all the ventilation that comes in, there's blood flow that meets it and carries the oxygen from the alveoli to the rest of the body. And this is the situation that we want. But this is not always the case. Sometimes you may have a place where you've got a blockage. For example, this vessel at the bottom is blocked. So even though you're getting air and oxygen here, there's nothing to carry it around. This is called dead space ventilation. Basically, you're ventilating, but it's a dead space. So the ventilation doesn't translate into anything. And then there's the second concept where it's opposite. Your alveoli is blocked. So this is the typical scenario here in ARDS, where you can see that your alveoli and the lungs are filled with this proteinaceous fluid, and basically your alveoli is blocked off. So although there is blood flow coming through, but basically this becomes a shunt because there's no oxygen to carry around. So this actually sets a nice stage to come into this new thing. Well, this is a very old concept of prone ventilation, but in the context of COVID-19 has received renewed energy. And the basic concept is, you've got this cartoon up here that basically shows you when you take into account gravity and a person is supine. So basically the dependent part is the back of the lungs, and the dorsal, the top part is actually the part under the sternum. You can see that the alveoli at the bottom of your, at the dependent part are very small, whereas at the top are very big. Just like the graph told you, the ventilation is better as you go to the top. And you can see that the blood flow is better as you are at the bottom. The color shading red tells you that. Now, immediately after you flip a patient over for prone ventilation, you can see what happens over time is that the alveoli tend to redistribute. And basically those alveoli that were very small at the bottom there, they have now become bigger and are ventilating well, and the perfusion is also holding in that area. And this was actually proven in several studies, and this is a very nice study. This is a PF ratio, basically something that we use to diagnose ARDS, and you can see that the moment the patients are prone, your PF ratio improves. And this is supine, and then again improves. So this is a very good concept. And basically this prone ventilation was cemented in by the Procedure study, which was a randomized controlled trial of about a can't remember how many, it was close to 500 people. And what they did is they took very severe ARDS patients with a PF ratio of below 150. And what they saw is a dramatic response at 30 days in mortality, literally 50% reduction in mortality. And there's very few interventions in medicine that can actually do this. So this was a very positive signal. And we know this since I think this paper was published in 2013. All right, the prone ventilation, I've oversimplified it, but basically it's got a lot of other benefits. And you can see them, the sternum moves forward, there's reduced atelectasis, there's increased lung volume, and then you decrease transthoracic pleural pressure, so that actually allows better mechanics on the lungs so that you can oxygenate better. But just to also say that when you perform prone ventilation, it's also very tricky. You need a very, very experienced team. I personally have kinked intravenous lines and central lines, and I've also once accidentally had an extubation that happened while we were something that you venture off into lightly. It's actually a team effort. It's very taxing. You basically, the ideal way to do this is you prone the patient for 12 hours, and then you put them back into the supine position and you prone them every 12 hours. But basically we do it sort of 8 to 10 hourly, because that's when we do it when you've got a big team of people around. So just to put the definition of ARDS up there. So basically the definition of ARDS has got 4 components. One is timing, that when you have this ARDS-like illness, it should have happened within 1 week of an inciting illness. The chest imaging should be consistent with ARDS. The edema should not be cardiac in origin. So basically this should not, you should have ruled out cardiac failure. And finally, the oxygenation, which is the key criteria, is the PF ratio. PF ratio is basically the partial pressure of arterial partial pressure to the FiO2 has to be less than 300 mmHg. And basically you can then, depending on how severe the problems are, you can grade them into mild to severe form. So just to keep the definition out there. Now exploring the second very important concept is the hypoxic pulmonary vasoconstriction. So you see the 2 cartoons on your right. The first one is basically depicting 2 alveoli, one that's receiving a normal amount of oxygen and the other one is not receiving a normal amount. There's a problem. You can see that there's a narrowing there. So it's not receiving a very good amount of oxygen. And as deoxygenated blood comes to it, you can see that this one oxygenates the blood fine, but this one actually doesn't. And when they combine together, they are able to increase the PaO2 to 80. Now, what happens is that physiologically, and this happens on a daily basis, even in healthy people, whenever there is a low oxygen concentration in one of the alveoli, it induces something called pulmonary vasoconstriction. And once it constricts like that, what it does is it shunts more blood into this well-oxygenated alveoli, and that actually causes the PaO2 to actually improve. So basically what it, at the end of the day, it does is alveoli that are non-functional simply shunt blood to more functional one, and that makes sense. So keeping this concept in mind, the normal ARDS presents like this: dependent edema and dependent consolidation. And if you can see here, it meets the criteria for the ARDS, and this is quite severe. You can see it's 84. And this graph basically measures Hounsfield units. Hounsfield units are basically a CT depiction of how light or how dark the structures are. So if structures are aerated, for example, these ones, they are classified as blue, and the more consolidated are classified as red. And here you can see that by the bulk of it is actually not blue, it's red. So because, and you can see it on the scan as well. So in this kind of setting, the alveoli is basically filled up. Now I want you to compare this type of patient with another patient. Here you can see that the abnormalities, basically the pathology on the chest, is actually minimal, but the patient is very hypoxic, and you can see that the PF ratio is equally bad. But when you look at the graph, The Hornsville unit exactly shows you here that there's more areas that are aerated. Now, when you when you when you first see this this CT, the first thing that comes to mind is, does this patient have a pulmonary embolus? Because how can you be so hypoxic with the chest X-ray looking so well, or the chest CT looking so good? The parenchyma doesn't seem to be explaining the PF ratio, and this guy obviously did not have a pulmonary embolus. What they did have is problem with this. They lost the drive, the hypoxic drive, and they did some elegant experiments to actually show a surrogate marker that actually shows the loss of tone, and they call it vasoplegia. Basically, their alveoli were not shunting blood into good alveoli. They were sticking to a situation like that, and that was the cause of the respiratory failure there. Now, SARS-CoV-2 seems to be doing this. There's two types of presentations when patients come to with ARDS. One is the traditional one that we know, and this is called the H type, and it basically presents with very low compliance. So the lung is very boggy. There's a high amount of shunt. You can understand shunt because it's all the alveoli are filled with. The blood is just simply bypassing the alveoli without oxygenating. The lung becomes very heavy, and the lung is recruitable because obviously when you recruit this, you push the alveoli open and basically force the fluid out. And this happens late in the course of disease. What happens early on is the L type. When the patient presents with the lung is very compliant, the lung weight is low, and there's no issues with recruitability because the lungs are very well aerated. So there's these two types of pathophysiology that seems to be coming out, and these have been described now. So the limitations of this model is that in order for you to know where you are, you need a CT. Chest X-ray can help, but not very much. I think you would need a CT. But if you don't have that and the patient is on a mechanical ventilation, you can actually measure the compliance using the ventilator and maybe assess for recruitability, and that can actually help you. We can talk about how to measure compliance on it, but it's simply, you just have to do an inspiratory pause and expiratory pause and basically look at the differences there, but we can talk about it if there is interest. So that's the second concept, is that it seems like we are losing the hypoxic pulmonary vasoconstriction, and we're developing a stage called vasoplegia, and that finally progresses into the type of the ARDS that we know, the H type. Now, the third concept that I think is important to remember is that ventilation is bad. Even if you put a normal person on a ventilator, they will actually develop injury, and there's all these traumas that can actually happen to the patient. But let me just show you this. It's quite an elegant experiment very long ago, I think in the 90s, where they took normal lungs and they connected it to a ventilator and they ventilated it. And you can see within 5 minutes, you already started seeing some changes appearing on the lung. And within 20 minutes, you can see this lung is grossly damaged. So ventilation is bad. But when we opt for ventilation, basically our backs are on the wall and we don't have a choice. So the fourth concept that I think I want you to appreciate is this concept called patient self-inflicted lung injury, and it's called PSILI. Now, PSILI is an injury that is inflicted by the patient on the lung. And this can happen in spontaneously breathing patients, but it can also happen on patients on a ventilator. So for example, this patient is on the ventilator and he's got ARDS in the dependent areas of the lung. What happens is that if the patient is triggering a breath on the ventilator, that effort of triggering a breath, especially when working against very big transpleural pressure, causes increased work of breathing, and that actually causes mechanical and shear stresses on the lungs that damage the lungs. So in this kind of cases, PEEP is indicated. PEEP is positive end expiratory pressure is indicated to keep the alveoli open and decrease the work of breathing. But basically, this is on a ventilator. So this is in case of patients like this, you can use PEEP. But there's the other scenario that I showed you, that the lung looks very well aerated. And in this case, the only way you can reduce the PCLE, if the patient is not intubated, you have to decrease the work of breathing. And the first thing that you do is you oxygenate the patient well. And high flow nasal oxygen is one way, and awake proning is something that I've just appreciated. Is also useful in patients who are not ventilated. But if on mechanical ventilation, the ventilation strategy for this kind of patients will be very different from this kind of patients. And in this kind of patients, because there is a dyssynchrony with the ventilation, because the patient is triggering breaths, you should also consider neuromuscular blockade and completely paralyzing the patients as well. But we'll talk about this in a bit. So that's the fourth concept. Oh, this finally, PCLE, because of this mechanical shear stresses, also causes increased in alveolar, transalveolar pressure, and causes exudation of fluid and increases vascular resistance, basically causes fluid to be more leaky and leak out and fill up the alveoli and cause all the bad things that we don't want it to cause. All right. So this is just the pathophysiology, the way from combining everything that I've told you and all the literature that's there. This is just a personal thing that I think is important to just realize how it works. So the first thing is, I think the initial insult, as opposed to some other viral infection, I think there is on two folds. The first one is the dysregulation of the pulmonary vasculature. The hypoxic drive is lost, and there's endothelial dysfunction. Something about this virus causes endothelial dysfunction. And the second one basically causes interstitial edema, which is also similar to the other viruses as well. And both of them, they lead to a decrease in PO2 at the end. And this causes the patients to become tachypnic with high minute ventilation and a very negative pleural pressure, but forget about those mechanical terms. And this here is the L type of ARDS that I explained to you. And because of this tachypnea and the increased work of breathing, and the patient is breathing very fast and very deeply, this causes PCLE, basically the patient's self-inflicted lung injury. And that causes vessel stretch and causes edema, as I explained to you, that the blood vessels become more leaky. And this basically spirals the patient into something called the Willi vortex. And this is basically something that drives the patient down. And as the cytokine storm sets up, you finally have got the more traditional type of ARDS that we know, with exudative edema and diffuse alveolar damage and fibroblast. There's also a component about microangiopathic process that's going on, which I'll tell you about in a second. So these are the two types that are coming to light. This is for prone ventilation. It should have gone there, but this is just the indication. I don't think we need to worry too much about that. So having told you all this pathophysiology and told you the types of ARDS that are currently, what can we do about them? So the first thing is we need to break the Willi vortex. Otherwise, the patient just goes into this cycle. And the first thing is to do is to reduce the inspiratory effort. So somebody comes to you, and the best way to do that is to give him supplemental oxygen, try and manage his pain and anxiety. If he's got a very high fever, bring that fever down. That will all reduce the patient's inspiratory effort. Secondly, you have to reduce anything that drives PCLE. So the most important thing here is the hypoxia that will also be driving PCLE. And here, of all the non-invasive ventilation, I think the high flow nasal oxygen probably has the greatest evidence at this point in time. And I'll show you this paper that was very recently published now. Initially, the worry was that using non-invasive ventilation was causing aerosolization of the virus. I mean, surely, even now, you should use these strategies in a room where you can confine patients. But if you look at the high flow nasal oxygen here, the one that I've highlighted, the spread was only 17 centimeters, and that's not bad. I mean, compared to the normal cannulae that you use at 5 liters per minute, the virus is shed to a distance of about 100 centimeters. So you can see the high flow is safe. So I really have changed my opinion on this. Initially, I thought it was not very useful, but seeing some of the patients that have come through, I think I'm going to be more, I'll try this more before I actually intubate, especially with the bed outcomes that we've seen so far. What about earlier intubation? I'll tell you that we have intubated all of our patients, and they have all done bad. I mean, 90% have done bad. We have admitted about 13 patients, and there's, I think, about 4 in the ICU currently, and 1 we discharged. The guy who we discharged basically came in with a step heart, but he also had COVID, and that's the only person who actually walked out. But the rest of them have done very poorly. And we've done proning, and they've just gone into a spiral. So for the L type of respiratory failure, you should try and avoid spontaneous breathing. So on the ventilator, you must make sure that the ventilator is doing the majority of the work. The patient is not triggering the ventilator. You have to use a lower PEEP, unlike the traditional ARDS that we use. We want higher PEEP. Consider sedation and paralysis, and prone ventilation is not very helpful. Only in a certain situations with this, maybe for a few minutes or so, for a few hours or so, just to stabilize the patient. If things are very bad, it can improve the perfusion a little bit, but generally not useful. And the H type, we basically use our standard ARDS ventilation. Basically, we use a higher PEEP, at least 10. Make sure your plateau pressures are below 30, and the tidal volume that you're using is between 6 to 8 mils per kg. And remember that 6 to 8 mils per kg is lean body weight and not the patient's actual body weights. And you basically try and maintain the targets. The targets for considering things like high flow nasal cannula or giving oxygen, the idea is the sets that you aim for is not very high. You should only aim for sets between 92 and 96. So that should be your target. As long as you're achieving that and a PO2 about just above 8 or so, that's quite okay. If everything else is good. So I just want to caution you, this field is very new, it's evolving very fast, the data is coming very quickly. The phenotypes that I've explained to you are basically based on this 58 patients from this group from Italy who basically are very good at ARDS, and they have published groundbreaking stuff. So their group has published this. There's no data available on this one because it's just submitted now. But this is what's emerging. But I also wanted to show you this other paper that from, I think this one, I can't remember where it was from, maybe the US, but basically they actually show a different scenario. So here they had 66 ventilated patients with a very low mortality of 16.7%. And very few patients had got near normal compliance. So very few patients had got that phenotype called the L type of ARDS. In this cohort, they basically saw the bog standard ARDS that we normally see. So there is some discrepancy, just so that you are aware that things are changing. What I'm telling you today may not be valid next week or the week after. Finally, I'll just say very quickly about coagulation and DVTs in the ICU. This is anecdotally very high, but basically the pulmonary thromboembolic events from ARDS are unknown, but this is something that we are looking at, and we have implemented a strategy where if your D-dimer is above 1, we anticoagulate. And this has been the case with 2 of our patients. And you can have this diffuse thrombi. But what is interesting is that if you look at the literature, in the 1980s, the standard ARDS already had this thing. So I'm not sure if this is novel or did we just miss it and now we're looking for it, that's why we're finding it. So that's also something we need to remember. So in summary, pathogenesis of COVID-19 seems to involve both an alveolar and an endothelial injury happening together. And that explains why these patients present in the way they do. Hypoxemia is usually disproportionate to dyspnea. I want to highlight this. These patients tolerate hypoxemia very well. And I think it's because of that, the mechanism is not the lung pathology, but rather the loss of pulmonary vasoconstriction and vasoplegia. And that's why they may look well, but they can be very sick. And the proposed phenotype have overlaps between them. You have to intervene with oxygen. That is the main thing earlier on, plus minus PEEP if there is progression. Proning is an option for awake and intubated patients. And finally, mortality for ventilated patients is variable. But in our setting and in the New York cohort, it was very high. So we need to do something about it. And these are just some of the research that I am involved in, but I'm happy to take any questions if there are. I'll stop here.
All right. Thank you, Dr. Ali, for the enlightening presentation. I'm sure we've learned a lot from it. I'd like to ask the audience, if you have any questions, you can unmute your mic and ask. If there's no questions, we could go on to the questions sent on the Google Forms.
Oh, sorry, 1 second. I have a question.
All right.
Dr. Ali, what do you think is the role of steroids?
Introduce yourself, so I also know who. Okay, I'll answer that, but just tell me your name and a little bit of your background. Just it'll be great because I don't connect with healthcare professionals in Dar enough. So just introduce.
Right, so my name is Zain. I've been in contact with you recently.
Yes,
We have had ARDS patients at Hindu Mandal. Most of them are in vent. We have tried to use a lot of steroids as well, just to maybe calm down the cytokine storm. But it's a Hail Mary. Whatever we do, nothing seems to work.
Okay. So what kind of patients are you seeing? Are you seeing the L type? Have you seen the L types, by the way?
I'm not too sure about that.
Okay. So just to answer your questions with steroids, listen, steroid, definitely you should not use it in early disease. Because the studies from influenza have shown that if you use steroids, there is worse outcomes. So you can't use steroids there. But for severe disease, when you've got your back against the wall, you are, as a physician, you're prompted to try something because no matter what you do. So in that situation, I suppose you can make a case for it. But basically, from all the experience that we've had now, steroids are not a good idea. Despite the fact that everything is a dysregulation, it seems like at that stage, when you want to throw the kitchen sink at the patients, the villi vortex and the cytokine storm is very, you can just not switch it off. It's gone into a spiral, and it's basically gone into a stage where you can't pull anything out of that. You know, it's too late, basically. And in early disease, we know that it doesn't work. So steroids is not the answer for this thing. So just to give you an idea, this is my own feeling, is that if you're using antiviral agents, like for example, I'm doing a study on chloroquine. So these antiviral agents that are effective directly against the virus should be used upfront when the viral load is high to prevent all this later. So basically use it in mild disease, prevent patients from coming to the hospital, getting onto the ventilator, because in our setting, if you get onto the ventilator, the battle is lost. In fact, you can make a case to say that, listen, after 3 months, if your mortality is 90%, should you even be ventilating patients? So in short, steroids is not the answer, but as you said, you are using it as a last stage.
Right. So that's one. The second question that I had is, I was reading regarding there was a published article recently shared that talked about the role of hydroxychloroquine in prevention of binding capacity. So what's interesting is ACE inhibitors do the same thing, but at the same time, studies show that they're not effective at all in preventing, like, getting COVID, like related symptoms or the complications.
Okay,
What do you think?
Yeah, I get your point. So the first point is that for the ACE inhibitors, there are 3 large studies that have been done, 3 large cohort studies. 1 did not show benefit, but 2 seemed to show that there is some form of protection. But there is an equipoise here. One group is saying that because the ACE inhibitor inhibit this receptor, chloroquine can't get into it. But the other one, and that's proven in laboratory studies now, is that Once you give ACE inhibitor to somebody, you upregulate the receptors, because remember that if you're blocking the receptor, physiologically you will upregulate the other ACE receptors to become more. So that was at the moment there's no clarity, but 2 studies have shown benefit, but this benefit is not causal. This is basically, large population-based studies that have looked at, so they haven't looked at it carefully. With hydroxychloroquine, at the moment, there is about 100 studies going on. So our study, as far as I know, is the only one that's looking at HIV and looking at it in HIV predominant situation. But basically, hydroxychloroquine has been punted as a prophylactic dose, so basically giving it to healthcare workers like yourselves who are in the front line, who are being in contact with patients with COVID-19 and as a protection, so as a prophylaxis. And then you've got chloroquine in mild disease, something that what we are doing. And then there is the Solidarity trial led by the WHO, which is actually looking at chloroquine in more severe disease, in hospitalized patients and patients on a ventilator. The jury is...
Thanks.
So
I have a question.
Go ahead. Just introduce yourself as well, please.
Yeah, Dr. Imran Hassam, Hindu Mandal. Yeah. So basically,
guys, this guy is my buddy, man.
So Ali, it's nice to see your way, and thank you for the really insightful presentation. But I have a question. In DAR, what we are seeing currently is that when a COVID is suspected, the doctors are prescribing azithromycin, vitamin C, zinc 40 milligrams twice a day, and vitamin D 60,000 IU. What is your take on this one? And number 2, would you suggest somebody who just came up with COVID, highly suspicious, would he start hydroxychloroquine early? And what's the dose?
Okay. So I will answer the first part of the question. Firstly, there is really no evidence to suggest azithromycin works in this disease. There was the French study that basically had a lot of flaws and it showed benefit. And subsequently, there was another study done in the US that actually showed worse outcomes in hospitalized patients, at least. So the jury with regards to azithromycin is out. There's lots of trials that are running there. I'll give you my practical take on that. So that's the azithromycin. With what other drugs, Imran? You mentioned azithromycin and vitamin D and zinc.
So vitamin C, vitamin D, and zinc.
Okay. So in my opinion, all those 3 vitamins are not harmful, but potentially helpful. My thinking is that, like in the other influenza study, if you take it when you're already sick, the benefit is very minimal. You should take it before you get sick. So basically as a prophylaxis. So if there is something. Having said that, there is a study that is published recently from China, basically showing that vitamin C does not help patients who have already become sick. In fact, there is a study here that is looking at lopinavir, ritonavir as a treatment for this, and they're using the placebo arm is actually vitamin C. So that would tell you that vitamin C is not useful. Zinc has been shown to be useful in other types of viral pneumonia, and there's also a mechanism via the chloroquine, hydroxychloroquine, that seems to suggest that zinc plays a role in that. But my feeling is those 3 should be taken as supplements rather than vitamin D. Actually, I think may play a part because it is an immune regulatory vitamin. So, but all this should be taken prior to. I think that my feeling of not giving azithromycin upfront to people would be the way to go. So for example, if you have a patient who is getting worse, now let's say this is the small percentage who are getting worse, I suppose anecdotally you have to just balance harm versus good. And if you feel that the good overweighs the harm, then I think you should try it. I mean, we should do everything and try and do everything to prevent these patients from getting onto the ventilator. So, and the same applies to chloroquine. So I have a lot of experience now with chloroquine because of our trial. And at the moment, again, I don't think that there is evidence, but if you have to use it, probably use it in earlier disease. With regards to the dose, now, okay, let me take a step back here. Chloroquine initially showed very good results. And then there was a veteran study from the US that basically showed that people who actually got chloroquine did worse. So there was worse, more people died who received chloroquine and azithromycin compared to people who didn't receive it. So chloroquine, at least in severe disease, is not, the evidence is very shaky. I think that where this comes maybe useful is basically in mild disease. And the dose that we are using is basically after collaborators of ours in Oxford, commissioned by the WHO, did some PK studies. And what we do is you load up the patients with 1,200 milligrams of chloroquine on day one and basically use 400 BD for the next 6 days. So 7-day dose at 400 BD. Which is slightly higher than the malaria one. Let me just add one last thing here, is that a Brazilian study that was using a very high dose, which was 1,200, showed that 25% of the patients actually had QT prolongations and were at severe risk of arrhythmia. So chloroquine is not a benign drug, is what I'm trying to say. And the evidence for its efficacy is not really very strong. But again, the feeling is, you know, when you got your back against the wall, you're trying your best, and there is some experimental drug that you want to try with a reasonable safety record. So Imran, it's a difficult question. I think you'll have to probably choose patients correctly, those who are actually getting worse. So there was a long answer to your short question, but
No, thank you. It helped. Thank you so much.
sounds like COVID, Imran.
Mazhar, go ahead. Then I will ask my question.
Assalamu alaikum, Ali.
Mazhar, salam. How are you doing, Mazhar?
Fine. Thank you very much for your informative and in-depth presentation. It's very nice. Just to add on your point about hydroxychloroquine, there was actually a study in the NEJM that was published yesterday, which again shows that there's no benefit, especially in these very sick patients. But I mean, this is a whole debate on its own. My question actually is more on the role of BCG vaccination and COVID. Do you think, what's your take on it? Do you think it has a protective effect or not? I know there's a trial that's going on now in Cape Town, but maybe if you can just give your view on it.
So I think that there is a signal there, but I personally don't feel that it is strong enough to explain the kind of, I think there may be another explanation. I think it'll turn out to be a negative study, but let's hope and wait.
Thanks.
Assalamu alaikum. This is Muhammad Zahir. I'm a medical geneticist working at the Mumbili University. First of all, thank you very much for a really beautiful presentation. Lots of new information that came out. Learned a lot. I have actually two questions. First, that we have seen at the moment in Africa, two countries that have spearheaded the sequencing of the viral genomes, that one being in Nigeria, the other one in South Africa. We do know that the virus is mutating, 2 mutations every month. And at the moment, over 30 viral strains have already been recognized and recorded. My question to you is, in South Africa, has there been any study conducted to look at the prognostic differences in terms of the patients that have carried certain different types of strains of the viruses? And secondly, here in Dar es Salaam, patients that are COVID suspects or strong COVID suspects that can be managed at home, we provide pulse oximeters to them to measure their oxygen saturation. What would be a good cutoff point to say that, okay, now this patient needs to be brought to the hospital for oxygen therapy? Thanks.
Excellent questions, I think. Firstly, the viral genome is very exciting, but the mutation rate is not particularly high, especially if you compare it to some other viruses, for example. So the mutation rate is there, but it's not particularly high. And to answer the question that yes, we are doing it. In fact, our own lab is involved in this, in the same part of the chloroquine study. There's a subset of patients who are undergoing something called CAS. CAS basically stands for cough aerosol sampling. And if you can see my screen, it's this thing here. And basically what happens is the patient sits here, and then you've got plates in this room that basically the patient, before coughing into this tubing, he coughs into the room, and we basically collect the virus, and you can culture the virus, and then you can sequence them. And basically later on, they cough into this tube that basically separates the big droplets from the small droplets. And the logic of doing it is that the smaller droplets, the less than 5 micron droplets, they can land on the lung surface and establish an infection because you can read them more deeply. The bigger particles, because of the way the anatomical where the airways are configured, they just hit the band and they deposit in airways where they can't really establish infection. So we're answering 2 questions. One is exactly what you said. We want to culture the virus firstly, and then secondly, we want to sequence them to see and compare them with regards to symptom score in mild disease. There's another group that is working in severe disease. So we will have that data. Regarding your second question, sorry, just remind me what that question was. I lost my train of
cutoff for the pulse oximeters for determining when the patient can be brought to hospital.
So this is very important. I cannot stress enough that these patients, when you see them in casualty, they are like the patient that I have in my mind is a gentleman who was able to talk on the phone, and he was talking full sentences with his family while sitting in the casualty, while in the PUI area waiting to be checked out. And when you measured his sets, he had sets of 88. And he was still able to have a conversation. So basically what happens in this kind of patients is that because of the pathophysiology I explained to you, they appear less sick. And it's very easy to sort of miss them. So to answer that question, you go back to your physiology. If you remember your oxygen hemoglobin dissociation curve, the top part is flat, but then there is a steep decline. So the steep decline means that a small change in sets means that there is a big drop off in the PO2, and that starts at about 92. So your threshold in such patients should be around 92. However, there is a very good definition that has been proposed by the WHO and the NICD, and they use the definition of sets below 95 as patients in whom you should actually consider hospitalization. For our trial, we use 94, but that's just a technical issue that we went around it. But absolutely, so if you are in the emergency unit, you've got a patient who is on oxygen and is only saturating at 92. Below 92, it's unacceptable. You need to escalate it to high flow nasal oxygen or maybe CPAP. But for monitoring purposes, in your case, you should use the WHO definition of 94 or 95.
Thank you so much. Just a supplemental follow-up. Would that be the same for heavy smokers or patients that are already asthmatic or have bronchitis? Because I can imagine that the baseline oxygen saturation is already quite low from the normal.
Correct. So you have to individualize patients. I mean, if you already know that this patient's baseline oxygen saturation is this, then you have to take that into consideration. But remember that when you assess these patients, you don't use one parameter. You are using the respiratory rate, you are using the blood pressure, you're using the pulse. And all of them have a cutoff. So the pulse rate of above 120 is an indication for hospitalization. Blood pressure below 90 or 60 diastolic is an indication for hospitalization. For sets, it's 94. And for respiratory rate is above 25. Are all indications for, so you use these things. Even if it is due to asthma, it's important to bring the patient to the hospital, because for asthmatic particularly, there is quite a lot of concern. Firstly, you know that nebulization has a potential for aerosolization, and if possible, it's better to use asthma medication with a spacer rather than nebulizing these patients. Because with the spacer, we've shown that the deposition is equally good, but nebulization has a potential for aerosolization and potential viral transmission. The other point is that in these patients, you might give steroids. because of severe asthma. Your back is against the wall. I mean, what else will you do? And in those kind of patients, you just want to keep them close by. We don't know what steroids will do to the virus. Well, we know that the outcomes are poor in people who give steroids for the virus itself. But in this case, you're giving it for asthma, and there's no other way around it. So I hope that gives you, it's a comprehensive assessment, and don't take one thing, take everything into context.
Thank you so much.
Okay.
Assalamu alaikum. Thank you, Ali, for such an informative presentation. It's Dr. Fatima Megji. Yeah, so I had a question regarding, again, what Mohammed Zahir asked about, the level of oxygen. So my question was regarding the patients who happen to need hospitalization. So let's say the SpO2 is less than 92, for instance, 88 as a number. So what happens ideally in our situation is we start the patient on oxygen via face mask, and that is low flow oxygen.
Correct.
And then if the patient deteriorates, then we consider the high flow nasal cannula or the positive pressure ventilation, CPAP. So I just wanted to know, do we have any clear-cut indications on when to exactly begin CPAP in a patient or high flow nasal oxygen?
Yes. So basically, got you. So basically, when you can't, the whole point is, remember the pathophysiology. You want to stop the damage. So you want to stop the PCL. This happens when the patient now, who's hypoxic, is obviously having an increased drive and it's causing damage to his lung, ongoing damage. So you give him supplemental oxygen and the sets correct to 94, his respiratory rate slows down, you are stopping PCL, it's all good. But let's say you give him supplemental oxygen, and although the sets were, he's in the steep part of the oxygen dissociation curve, and his PO2 is basically 6. So you got the PO2 from 6 to 8, but his sets only went up to 90 now. And in these kind of cases, anyone who basically cannot achieve sets of above 92 on nasal prongs or face masks, oxygen, that's an indication to escalate treatment into non-invasive ventilation. The one thing that you want to definitely stop is a crash intubation, because firstly, there's no time when there's crash intubation, there's no time to get your PPE ready, the staff will suffer, and it's a whole problem. So 92 is the threshold that you start your non-invasive measures. High flow nasal oxygen, I think, should be tried first before CPAP or BiPAP. And once, if the patient stabilizes, that's well and good. And just remember that you just make sure that the thing fits properly. If it doesn't and it's blowing to one side, the aerosolization is 60 centimeters. So I hope that answers. So 92 is the cutoff that you have to maintain the sets above that.
Yes, well understood. Thank you.
Assalamu alaikum, Ali Asghar. This is Muhammad Manji. So good to hear from you and get all this information.
My pleasure as well.
Ali, what is your target SpO2 when you are treating these patients? That is my first question. And the second question is, if you look at the temporal history of this disease, these patients, the first week is usually the infective week, the second week is usually the storm, the cytokine storm. So technically, someone who goes through maybe 20-21 days, someone can get very, very sick, but then goes through about 20 to 21 days of the illness. They will usually are aimed at keeping this patient alive for that span of time before nature kind of takes over. What do you have to say about that?
Okay, I heard the first two questions, but I could not hear the last one. But let me answer. So the target saturation at the moment, the two big guidelines that are out there are the WHO guideline and the surviving sepsis guideline. Both of them recommend keeping the sets between 92 and 96. Remember, at the end of the day, oxygen is toxic. So you don't want to over-oxygenate anyone. I mean, if you can aim between 92 and 96, that would be your target. Your question about the phases, I didn't understand very well, Mohammed. If you can just repeat, because you broke off a couple of times in between.
So what I'm trying to say is that this disease, over all these months that we have studied this disease worldwide, we have understood that it comes in phases.
Yes, correct.
So there is the first part of the disease, which is the infective phase, which is pretty harmless as such. And then
Yes.
you go on. Then you go on to the second part of the phase, which is now the storm, yeah, the cytokine storm.
Correct. Yeah.
And usually that will either kill the patient, and eventually, if the patient recovers from that, then he's done. Then he's okay.
Yes.
So what I'm saying is that, for example, in our setup, we see a lot of patients who are now on for example, day 20 of illness, okay, or day 21 of illness. You do their control X-rays. Their X-rays were very bad in the start, okay. You treated them in whatever way that you could. Now they have reached day 20. They are alive. Sets are maintaining at 94%, okay. Heart rate is in control, hemodynamically stable, not on oxygen. You do another control X-ray on day 20, day 21, you are still seeing some changes on the X-ray. Are those changes just inflammatory, and probably they will just go away with time? Is there a reason to understand or believe that the disease is still active even if it is day 20?
Good point. So, Mohammed, to just clarify that whenever you are looking at an X-ray, whenever there's an infiltrate, it is very dependent on how quickly this infiltrate changes. So, for example, if you take an elderly patient, the infiltrate may be exactly the same in 3 months. So it takes very long. So it takes very long for the X-ray to change. And by long, I mean weeks to months. So if your day 21 X-ray shows or is unchanged, that doesn't worry me too much. I would ask you that what are the other parameters? If the pulse rate in the second week was 120, or now it's come down to 105, and the patient is feeling well, is breathing well, his sets were 92, but today is saturated at 95, then you should go by that. I would not worry too much about the chest X-ray. If you want to study imaging in these patients and you want to pick up the change, then the chest X-ray is the wrong thing to do. You should do a CT, which is basically not indicated in outpatients like this. So I would not worry too much about chest X-ray infiltrate persisting.
Thank you, Ali. Good to hear from you.
One other caveat there is that you should just X-ray this patient maybe 3 months down the line, just to have a baseline X-ray to see after this what the lung looked like. Because then in future, if this patient gets a pneumonia, you want scar, or is it something new? So it's always good to sort of document when the patient is better from the symptoms.
Sawa. Thanks, Ali.
Pleasure. Should we?
Ali, just want to ask you one more question.
Of course.
What would you suggest would be the sets cutoff for patients who have got chronic lung disease, your COPDs and your ILDs? Especially because what we're doing at the moment is we're doing teleconsultation for patients, and we get various demographics, you know, old elderly patients with different comorbidities, and some of them will have chronic lung disease. And we have used a cutoff of 95%, you know, generally. For anybody who has got a cutoff of 95%, you know, we would give them a SATS probe to monitor. If it continues to deteriorate, then we'll ask them to be, you know, admitted to a hospital.
Correct. Yeah.
What would be, you know, I mean, patients with chronic lung disease will have a baseline of 92, 91, 90, depending on how severe the lung disease is. They may not be symptomatic. So how would you approach that in a patient with, say, you know, COVID and this chronic lung disease?
Yeah, so again, this is a very difficult thing, because now you've got two illnesses in one patient. I think doing this telephonically is extremely difficult. I think you would have to see the patient and again do a global assessment and maybe look for other parameters of severity other than sets. So for example, if his respiratory rate, despite having an oxygen saturation of 90, is still below 25, which is the cutoff for severity, then you can cautiously continue monitoring him. But it's a bit of a fill, Mazhar, as you know, that some these patients, exactly, you know, sometimes you just look at them and you know that there's something wrong about this guy. But it's very difficult, especially when you're consulting telephonically. I think you guys are working in very challenging situations. I'm glad I don't have to do this, but it's very difficult.
So basically, what we would do is we would ask the patient if the patient is actually changed from his baseline. So normally they would have some sort of dyspnea, and if the dyspnea has worsened a bit more than, you know, or the work of breathing is increased, we wouldn't really take the sets into consideration, but rather take, you know, the level of dyspnea, work of breathing, you know, into consideration, and perhaps suggest that they should go to the hospital.
Correct. I think that's a very sensible and a pragmatic approach, which will work nicely.
Asante.
My pleasure.
Okay, so thank you for your questions. I hope the questions have been answered, including the ones from the Google Forms. We've come to the end of this session. I'd like to thank Dr. Ali once again for taking us through this topic, and to the viewers for joining us this evening. Dr. Ali, would you like to say anything?
No, it was a pleasure linking up and meeting so many of my friends, actually. So it was fantastic. Thank you.
Okay, thank you. The session has been recorded and we will be posting it on our YouTube page. Further updates will be sent on our WhatsApp group. Thank you for joining us. Stay safe and take care.